I wanted to jump right into our next session, and we are going to now hear from Dr. Catherine Loman-Hoerth, who directs the ALS Center at UCSF and follows over 375 patients with ALS. And she's had 100 new referrals a year at that rate, and the ALS Multidisciplinary Center at the University of California, San Francisco. So this center is certified by both the MDA and the ALS Association, and has full multidisciplinary team of professionals, including speech pathology, dietitians, social work, PT, OT, respiratory therapy, nurses, and neurologists. And she did train under Richard Olney and took over as director of the ALS Center in 2004 when he retired. And she's also a full professor of neurology at UCSF and has significant experience in ALS clinical trials since joining the faculty after completing her neurology residency and EMG fellowship in 1999. So you have a lot on your plate, Dr. Loman-Hoerth. I will turn it over to you and you can begin your presentation.
Thank you so much. I appreciate everyone being here today. I'm going to pause at a couple of times during the presentation for you to ask questions. So feel free to at any time to type questions in the Q&A, and I'll let you know when those times come, when we'll take some breaks. So I'm going to talk today about the overlap of ALS and a condition called frontotemporal dementia. Let me just see if I can advance my. So most of you on the line are probably very familiar with ALS, otherwise known as Lou Gehrig's disease. It's a disease that is quoted as having a survival of 3 to 5 years, but there is a very wide range. I have had patients who have died, unfortunately, just a couple of months after their first symptoms, and I have other patients who are still walking 10 years later. So it's very variable. It is the most common adult onset motor neuron disease, and we don't understand very much about what causes the disease, which makes it very hard to try to treat it. It is a diagnosis of exclusion, so we don't have a marker that says, yes, you have this disease, like you can get a blood test that will tell you if you have diabetes. ALS is different than that. We have to look for all of the other things that look like ALS, and when all those things are negative, then we end up coming to the conclusion that that is the diagnosis. I wanted to briefly talk about Lou Gehrig's case because he illustrates a typical way in which ALS can progress. He started out having some difficulty with his 1938 season. His weakness started in his legs and then spread to his arms. When he was skating in the off season, he started having falling, dropping things. He started to play fewer games. I think he was known as hardly missing a game. And then by a year later, he only played 8 games. He stopped entirely in 1939. And was diagnosed the next month. He then started to develop some difficulty speaking and passed away about a year after that. And this is a quote from an article, neurology article describing his case and his story. And the quote says, "But even in the midst of it, he saw himself not a mere victim of a form of paralysis, but a symbol of hope for thousands of sufferers of the same disorder." And I feel this way about most of my ALS, many of my ALS patients who continue to advocate for others and are very involved in trying to help others with the disease while they are suffering from it themselves. ALS, as I mentioned, is a diagnosis of exclusion. It has 2 characteristic symptoms: upper motor neuron findings and lower motor neuron findings. And symptoms of upper motor neuron findings are things like slow speech, a brisk gag, or a jaw jerk when the neurologist taps on the jaw, brisk reflexes in the arms and legs, and spasticity or stiffness in the limbs. Lower motor neuron findings are atrophy of the muscle, fasciculations or twitching of the muscle, and weakness. And this picture on the left shows in the dashed lines where the upper motor neurons are located, and then the solid lines are where the lower motor neurons are located. And so as you can see, an arm will have both upper and lower motor neurons. It's the same for the leg. But it's this combination that's quite unique about ALS specifically. And so there are criteria to diagnose. Patients must first have both upper motor neuron damage and lower motor neuron damage, and then it needs to spread. either within a region or into other regions. And then there needs to be the absence of other diseases by EMG or by imaging. And so there are many things that look like ALS, very common things like radiculopathy, which is a pinched nerve in the back or in the neck, a brain tumor. We don't see as many of these cases anymore, but people who had polio as a child, as they age, can sometimes develop worsening weakness in a muscle that's already weak. There are types of neuropathies that can look like ALS, including one called multifocal motor neuropathy, and that's treated differently than ALS. There are certain endocrine problems that can look like ALS. Lead intoxication. Lead paint is common in homes, and that can cause a syndrome that can look like ALS. Certain infections like Lyme disease, HIV, West Nile virus. And then there are diseases that are considered connected to cancer, things like lymphoma or monoclonal gammopathies. And then there are other motor neuron disorders listed here. I already talked about polio and West Nile, but there are also a couple of genetic causes. Spinal muscular atrophy is a condition that most often starts in childhood, is more symmetric than ALS, and is just a lower motor neuron syndrome. And then Kennedy's disease is also an inherited disease, tends to present a little later in life, also very symmetric, and causes a motor neuron disease in men, since it's X-linked. So I mentioned in my first slide about how variable ALS is as far as its progression. It's also very variable as far as where it starts. About 25% of the time it can start with difficulty speaking and swallowing. The rest of the time it starts with weakness in the arm or in the leg. And very rarely, around 1% of the time, it can start with breathing difficulty. People vary as far as how quickly they progress and which regions are affected first. Someone might start with difficulty swallowing and then start to have trouble walking. Someone else might start with weakness in the hand and then progress to difficulty speaking. So it's very variable about how it progresses, but it tends to be fairly linear. So if a patient is rapidly progressive, then they typically tend to stay rapidly progressive, or if they're slowly progressive, typically will stay slowly progressive. And it's really, really important to carefully categorize patients into these clinical categories to help with research. Because as you can imagine, if you have too many slowly progressive patients in a placebo group in a clinical trial, then you might miss an effect of a drug. Vice versa, if you have too many slowly progressive patients in the treatment group compared to your placebo group, then a treatment might artificially look like it's working when it might not. And so the thing I'm mostly focusing on today is an aspect of this heterogeneity, which is the cognitive and behavioral involvement, including frontotemporal dementia. And so before I get into talking about what is frontotemporal dementia and talk about some of the cognitive and behavioral problems with ALS, I wanted to just stop here to see if there's any questions just around ALS in general before we get into frontotemporal dementia.
We actually have a couple questions.
Sure.
What is considered rapid progression versus slow progression?
It's a great question. So there's something called the ALS Functional Rating Scale, which is a scale that's used to track how patients progress over time. And I'm sure if you have ALS, you're very familiar with this questionnaire. There are 3 questions around what's called bulbar function, speaking, swallowing, 3 questions around your arm functioning, 3 questions around your leg functioning, and 3 questions around breathing. And that scale tends to drop at a rate of about a point a month. And if a patient is dropping faster than that, then that's usually considered rapidly progressive. If they're dropping slower than that, then that would be considered more slowly progressive. And I think at a practical level, I think of someone who's rapidly progressive as someone who passes away a couple of years after their first symptom, and then someone slowly progressive, someone who is, say, walking, 5 or 10 years after their first symptom. So that's, I think, but it's something that your neurologist should be able to tell you whether you're in a rapidly progressive group or a slowly progressive group.
Okay, that's great. And we had a question that was submitted earlier in the day, and I wanted to hold it for you. She says, my mom over the past 2 years continues to decline. Initial diagnosis was bulbar palsy. Now the doctor is calling it ALS. Her symptoms are only upper body, no function in her left arm and hand, incoherent speech, drooping mouth, trouble drinking from a bottle, and she's having a hard time bringing up any mucus. And she says her right arm and hand still function, but seems to be getting weaker. So considering her symptoms, she's wondering, is that ALS or PLS? And she's 83 years old.
Yeah, it's a great question. And the main way we distinguish between ALS and PLS, which is the pure upper motor neuron form of the disease, is the EMG. So if the EMG, which is a test where needles are put in the muscles and nerves are stimulated electrically, if the EMG is normal, then the patient has the types of symptoms that you're mentioning, then the diagnosis would be PLS. If the EMG is abnormal, then the diagnosis would be ALS. And one thing that's important to know is that a patient can start out as PLS and then over time can change into ALS. So for most PLS patients, we'll do an EMG every couple of years just to check to see if the patient has progressed into ALS.
Oh, okay. That's interesting. Okay. And then we got another question that has popped in. Is cognitive impairment, such as FTD, more common in bulbar onset patients?
It's a great question. Yes, it is slightly more common in bulbar patients than limb onset patients. But there are plenty of limb onset patients that can have cognitive and behavioral abnormalities too.
Okay. Well, I don't see anything else, so you can
go ahead. Well, I will continue.
Thank you for pausing and doing that.
Yeah, thank you. I just wanted to be sure to answer questions as they come in. So now we're going to turn to talking a little bit about what frontotemporal dementia is. So frontotemporal dementia involves atrophy of the front part of the brain and the temporal lobes of the brain. And patients present with personality difficulty, language problems, or behavioral disturbances. It is progressive and it is irreversible, exactly the way ALS is. And it's not at higher risk in patients with pseudobulbar affect. So I should take a minute to define that because we just talked about patients with bulbar onset. So that's patients with difficulty speaking and swallowing. When patients have ALS, about half the time they can have trouble with easy laughing and crying. So laughing at something that's not really funny or crying out of the blue with a commercial that's maybe a little bit sad, things like that. And so that's a symptom that sometimes people can confuse a little bit with frontotemporal dementia. So that is not associated with the disease. There are very clear criteria established to diagnose frontotemporal dementia, and it's very different from Alzheimer's disease, where Alzheimer's disease involves memory problems. Patients with frontotemporal dementia do not have problems with their memory. There are three main types. There's the frontal type, in which patients have symptoms of apathy, being disinhibited, having not speaking as much, being disorganized, having poor insight. And then there's the temporal variant, where people have difficulty with words, understanding words, trying to find words, but they have good insight into the fact that they're having this word finding problem. And then the non-fluent variant, this is a condition where patients have it takes a lot of effort for them to speak and their grammar is not correct, but they have good comprehension. So those are the three main ways in which frontotemporal dementia can present. There's a genetic overlap between these two conditions. So 10% of the time, ALS runs in families, and about 40% of the time, FTD runs in families. And a family member may have only ALS, only FTD, or they may have both together. And this was a clue that there may be a similar pathology between these two conditions. And so we were curious about whether these conditions overlapped in sporadic cases. And I'll present some data about that coming up shortly. But this is just a typical family where ALS and FTD may run together. And when the disease is familial, it's very strongly familial. So it's called autosomal dominant, meaning a parent needs to have it. So for those of you who have ALS today, if you're concerned about whether this is in your family, if both of your parents were healthy and did not have frontotemporal dementia or ALS, then it would be very unlikely that this condition runs in your family. And so this figure just shows a family tree. The circles are women and the squares are men. And this shows that patients in pink have ALS, those in green have FTD, and then the ones where they have both colors, they have both. And so you can see that this is a family in which there was quite a number of patients that were affected. And this just shows what the MRIs look like. A patient who is normal on the left, and then someone who has FTD on the right, who was very early on, didn't have a lot of atrophy, and then in the middle is a patient that had both of these conditions. And the way you can tell if there's atrophy on the MRI is you look at the white. So the white is basically empty space that's filled with fluid. And so in this situation, you can pretty clearly see on the MRI in the middle, there's more white, there's more free space. So that means there's been atrophy of the brain. So when we looked at 36 patients that had FTD and no known motor neuron disease, we found that 14% of them met criteria for definite ALS. And then another 36% had possible ALS, symptoms just in one limb, in one body part. And then 14% had just twitching of the muscles. One patient who had the twitching after a year developed into ALS, and then 17% had swallowing difficulty, which sometimes can be associated with ALS, but sometimes not. And then 5% had other abnormalities. So we were surprised that there was really, that this was more common than had been previously thought. And then we turned the question around and we looked at patients with ALS to see, did they have signs of frontotemporal dementia? And we did a screening test where we asked patients to think of as many words as they can think of that start with D and as many animals as they can think of. And in general, you should be able to name at least 13 animals in a minute and at least 9 D words in a minute. And 31 of our 100 ALS patients that we studied had trouble with this test. And when 17 of them agreed to go on for further evaluation, and 15 ended up having a confirmed diagnosis of FTD. And then 2 tested low normal on the language. And then for those who were normal on the word generation test, 27 agreed for further evaluation, and we found that 8 of them had confirmed FTD. This was the behavioral variant, not the cognitive variant, if you remember the different variants. And then 19 were normal. And so just to summarize here, about half of ALS patients are completely normal with no difficulties with behavior or word finding trouble, but around 70% had some subtle problems and then with behavior, and then 9% had some subtle problems with executive functioning, and then 22% met criteria for a diagnosis of FTD. This just shows that in this study we looked at MRI imaging to see if there was an imaging correlate to what we were seeing with our clinical testing. And what we found is looking at 10 patients with ALS and 10 patients who had ALS and FTD, we found that there was atrophy really in all of these patients in the areas that are typically affected in FTD, but much more severely in those patients with ALS FTD. And this is shown in red. So red means atrophy in this particular slide. And you can see that there is more atrophy in the A group, which is the ALS FTD group, compared to the B group, which is the ALS alone. And this is a more recent paper showing similar things. That the top half of the chart are patients with ALS FTD, and the middle are the bottom half are patients with different forms of FTD without ALS. And so just at a quick glance, you can see the color shows atrophy, that those patients with ALS FTD have very similar looking brains to those who have FTD without the ALS. And then at the very top are patients with ALS with no signs of FTD, but they too still have some areas of atrophy that are different than what you would see in a pure motor disease. The pathology is also similar between ALS and FTD. So there's a protein that has been found, it's called TDP43, and there are mutations in this protein that can cause both ALS and FTD. So basically, whether you have purely ALS or purely FTD or both, the pathology is similar in these different conditions, suggesting that it has potentially a common cause. And then I wanted to just say a word about environmental risk factors, because I think you've probably heard some of this in the news. There's something called chronic traumatic encephalopathy, or CTE. And this is something we've known for decades in boxers, that they have a higher risk for dementia. And also trauma has been associated with Alzheimer's, FTD, ALS, as well as Parkinsonism. And this TDP protein that I mentioned is also found in these cases as well. And then there's an increased frequency of degenerative diseases in trauma-causing professions. So soccer players are more at risk for getting ALS. They use their head a lot to hit the ball. NFL players are 4 times more likely to get ALS. And military veterans are 2 times more likely to get ALS, and it is higher in deployed veterans versus non-deployed veterans. And so one thing that is very important, if you have ALS and you have any history of serving in the military, the military has recognized that that the patients who have ALS and did serve may have, that this service may have caused them to potentially be more at risk to getting ALS. And so they have compensated veterans who have gotten ALS with a higher pension and other financial benefits as a result. So it's very important, if any of you are a military veteran, to know that. And the NFL has done the same. And so I don't know if there are any former NFL players on the line who have ALS, but there is also financial compensation from the NFL as well. So one question is, why is this important? Is this just a research topic, or is there a clinical importance to understanding if someone has cognitive or behavioral problems when they have ALS? And it is important for a few different reasons. It's important because there is a reduced survival rate by about a year. Patients often have difficulty complying with typical ALS recommendations, such as a feeding tube or using a breathing machine non-invasively. It can often cause distress for caregivers, not understanding what's going on, and oftentimes patients can have a poor safety awareness, falling more, choking. And it can be difficult for patients to manage important decisions. For example, if they were always managing the finances, sometimes patients will start to make risky financial decisions or have a poor judgment with certain financial matters. And then it can have implications for stem cell therapy. So stem cell therapy is one of the therapies being tested in ALS. And if we just treat the motor neurons and don't think about treating the other parts of the brain that can be affected, then we may have a situation where someone is continuing to progress as far as cognitive or behavioral problems, but yet their motor weakness is doing better with stem cell therapy. So it's important to think about treating the entire patient and all of the different areas of their body that are affected. One thing that is also important is that a lot of things can look like FTD. A lot of things can cause cognitive or behavioral changes that have nothing to do with this type of dementia. So things like having severe depression or an underlying psychiatric disorder can often mimic FTD. Pseudobulbar affect can sometimes be confusing if someone's crying inappropriately or laughing inappropriately. That can be caused by something different. And then depending on what a patient's breathing capacity is, having low oxygen or retaining CO2 can make people confused and have difficulty thinking of words. Someone's intellectual level or baseline or educational level can also impact how well someone may test on score on some of these tests. And then the level of disease progression can definitely limit testing as well. So if someone is more advanced, they may have more difficulty with doing some of the testing if they can't, for example, write fast enough or speak quickly enough. And so I had mentioned that ALS and FTD run in families, and there was an important discovery that happened in 2011 in which a gene was found that was responsible for for 40% of familial ALS cases and 25% of FTD cases. And this gene is called C9orf72, and it's caused by an expansion of this particular repeat in chromosome 9. And it's sometimes found in sporadic cases too, 7% of sporadic ALS cases and 6% of sporadic FTD cases. And the reason this was exciting is because it gives another target to be testing drugs besides the SOD1, which only affects 1% of ALS patients. And potentially a treatment that is aimed at C9orf72 could impact both ALS and FTD. And clinical trials are in progress testing genetic therapies against this mutation for both ALS and FTD patients. So in summary, about 30% of FTD patients show signs of definitive or possible ALS, and then 50% of ALS patients show some type of cognitive or behavioral abnormality. The C9orf72 gene is the most common genetic cause, and there are 4 different subtypes: ALS, ALS with cognitive impairment, ALS with behavioral impairment, and then the classical frontotemporal dementia. And the way these 4 subtypes were arrived at is a variety of consortium meetings with experts in both ALS and frontotemporal dementia met together to try to understand what would be appropriate tests to be using, given that ALS patients often have hand weakness or difficulty speaking, tests that would not be impacted as much by the symptoms of ALS, and thinking about controlling for the things that I already mentioned, things like depression, lack of oxygen, things like that. And over time at these meetings, the diagnostic criteria were refined further, and a paper was published in 2009 that with specific criteria that are still used today to determine whether a patient has ALS and frontotemporal dementia, with strict criteria that had been designed in the dementia community, and then or whether they have this more mild form of ALS behavioral impairment or ALS cognitive impairment. And these are the criteria. Patients need to be at or below the 5th percentile compared to age and education matched norms. They need to have at least 2 distinctive cognitive tests and that are sensitive to executive function. And then importantly, it needs to not be accounted by a patient's pre-existing intellectual level. And we need to make sure have you ruled out any other cognitive conditions. And then this is the last slide before I'll get into some questions. These are the behavioral criteria that are used, the NERI criteria or the Hodges criteria. And you can see how important it is to control for some of these factors in ALS based on a patient's physical abilities. For example, decline in personal hygiene and grooming, or dietary changes. These can be very normal changes that happen over the course of the disease. And so it's important to separate that out in using these particular criteria. So there's still a lot that we don't know about the condition, about what is the rate of progression of cognitive behavioral deficits, what's the best screening interval and tools for testing, what is the impact on survival and other outcomes. How frequent is this mutation in the sporadic ALS population, and how will treatments for ALS impact FTD and vice versa? And so I'm going to stop here and see if there are any questions, and then if not, I'll just do a little bit more towards the end, but I'll stop and see if there are any questions for right
now. All right, we have a couple. Does PLS have the same prognosis as ALS?
It does not, in the sense that patients with PLS progress much more slowly, and it can sometimes progress so slowly that people die from something else, and a heart attack or stroke or something at the end of their life. But most patients with PLS, with enough time, do transition into ALS, and then ALS is a fatal disease. And so I would say most patients with PLS ultimately will die from ALS, but if they're slowly progressive enough, then they may die from something else. So I would say it has in general, a better prognosis in terms of being more slowly progressive and potentially so slowly progressive that people could die from something else.
Okay. Do you have any recommendations for caregivers on how to deal with patients with FTD?
Yes, there are a lot of wonderful caregiver organizations that are specialized in FTD, and there are support groups. There's also a variety of resources, and potentially we could provide access to some of those resources later. But like the Caregiver Alliance is one that focuses on patients with dementia and has a lot of very practical tips and suggestions.
Okay. And what are the best screening tools to assess for cognitive impairment or FTD?
Yeah, it's a great question. So I think the word finding test, so things like asking people to name, like I mentioned, how many start with D in a minute or how many animals in a minute, that's a good screening for the cognitive aspect of it, the word finding. And there's a very ALS cognitive behavioral impairment screen that takes about 5 minutes that is also very good. And then for behavioral impairment, there's a series of questions that caregivers are interviewed about when they're in clinic that help identify if there have been behavioral changes, thinking about the patient the way they were before they started to develop their ALS symptoms and the way they are now. There's certainly people that have behavioral issues that are just part of who they are, and that's been lifelong. But what we're looking for is a change. So someone who was behaving one way, and then after they developed the ALS symptoms, started to behave a different way.
Are you familiar with the ECAS?
Yes, yeah. Mm-hmm.
Do you have any comments on that?
Yes.
Okay.
Yeah, it takes about 20 minutes, but that's another good screen.
Okay. Do you see many ALS neurologists diagnosing ALS FTD, or are most patients sent to dementia specialists for definitive diagnosis?
That's a great question, and it really is not appropriate for an ALS specialist to diagnose someone with any type of dementia, because we have not gone through that formal training. Mm-hmm. And since when we suspect that someone may have FTD or any other type of dementia, then we always refer to our memory disorder colleagues to do very lengthy testing that can take half a day.
Wow, okay.
Detailed imaging to make absolutely sure that that's what's going on and it isn't one of those other things that I mentioned. So I think what we often do as ALS neurologists is we can identify if there are some cognitive or behavioral changes and can advise the family and patient about how to cope with those. But we do not make a formal diagnosis of dementia in the as ALS specialists.
That's a good point to know. Could you repeat the scale that is used for criteria discussed for determining rapid versus slow progression? You said 1
Yeah,
point.
so it's called the ALS Functional Rating Scale. And you can just Google it. It's ALS FRSR, and there'll be a PDF that will pop up, and I'm sure you'll recognize it as a scale that you get asked pretty much every time you go to clinic.
Okay.
Any other questions in the chat or in
Nothing is in the chat. No, we are all caught up.
Okay, I'll just finish up here quickly with a few other things, and then we'll see if there are any final questions. So we wanted to learn about how cognitive behavioral status changed over time. We've talked about how it can be diagnosed and how it can be recognized, but we wanted to see what happens over time. And we were curious if there was an association between disease stage, survival, patient quality of life, and caregiver burden. And what we did is we did this ALS CBS, which I mentioned is a 5-minute screen. And we also did a caregiver survey of behavioral impairment, and then just repeated those same tests in 6 to 9 months. And these are the tools that we used in our study. And then these were the outcomes that we were looking for. And then this is just a picture of the ALS cognitive behavioral screen that takes 5 minutes. It focuses on attention, concentration, tracking and monitoring, and then initiation and retrieval. And then this is the ALS behavioral screen, which takes just a few minutes as well. And basically it's just 15 questions about, frontal lobe media behaviors. And I had mentioned in the FTD criteria, there will be questions about, is there a change in food preferences? Well, that's too broad for an ALS patient because ALS patients often have to change their food preferences as things become harder to swallow. But what we focus on in this question is we say someone eating more, having a new preference for a particular food like sweets. That's just a way the question was modified to be a little more specific for ALS. And then what we basically found is very similar findings to before, that about half of patients had some sort of cognitive behavior, and then a smaller number had behavioral impairment. And it did not correlate with disease stage. Cognition didn't particularly change much over time. Some people got a little better. We like to think that's based on our treatment that we often provide with various breathing equipment to help with any hypoxia or any retaining of CO2, and medications that can help if someone's having behavioral impairment. And then behavior though did worsen in the group that was initially normal. And then for behaviorally impaired patients, the progression of the deficits was more variable. Like I said, I think probably because of some of the treatments we're able to provide. So the bottom line is there was some changes with behavior over time, but not cognitive. And patient quality of life went down in patients who had associated frontotemporal dementia, whereas historically over time, most ALS patients have a fairly good quality of life despite the disease getting worse over time. And then the next thing I wanted to point out is just that caregiver burden. So over time, the caregiver burden does get worse as if the behavioral impairment is worse. And that makes sense. If the patient is not paying attention and they're falling and not using their walker, that's going to be quite stressful for the caregiver and more work. And so just in conclusion, we found that cognitive behavioral deficits are not associated with motor weakness and have separate trajectories, and that routine screening can be helpful with referral to formal memory and aging center, as I mentioned. And then in a typical cohort, cognition remains stable over the period of time that we measured. But behavior can decline in patients who are initially normal. And so maybe a benefit from rescreening. And then the severity of behavioral symptoms predicts caregiver burden. And just this brief screen that I showed you for behavioral symptoms can identify patients and caregivers who are at risk for having worsening quality of life, and can help with some educational interventions as well as medications to help with some of the symptoms. And so final summary, we've had a lot of advances in genetics that have led to new animal models, potential disease therapies. Neuroimaging developments may allow for earlier diagnosis of ALS and FTD. And then the common pathology between these disorders may allow for therapies that can be targeted not only at ALS, but also at FTD. And then cognitive and behavioral screening is very important for research and as well as for clinical care to make sure we're categorizing patients in the right buckets in these clinical trials so that we make sure we have equal number of patients in the different groups. And then caregiver burden is important to address, as well as interventions employed as patients hopefully live longer with ALS with some of the treatments that we have. So thank you very much. I'll just see if there are any final questions before we give you a little break for the next session.
Thank you. We have one that came in. Is the ALS FRS going to be updated? There are many clinicians that have said it should be updated or changed. What are your thoughts on that?
I love the scale. I feel like it's been shown to be the best outcome measure in clinical trials compared to many other different types of measures of strength, of breathing capacity. So I personally really like the scale and rely very heavily on it for both clinical care as well as for research.
All right. I don't see anything else in the queue, so thank you very much for your time this afternoon. It was great. All the information was really, really easy to understand, and I think that this is something that is very common, and we don't know a whole lot about it. So thank you very much for sharing.
Thank you. Happy to be here today.